Hello everyone, and welcome to another lecture in my series on common conditions seen in the cardiac telemetry unit. The topic today is syncope. My objectives for this lecture will be first for you to know the definition of syncope, for you to understand the standard classification of syncope and recognize some common syncope mimics, to effectively triage a patient who presents with syncope, to order appropriate testing to evaluate possible causes of syncope, and to provide effective treatment to prevent and reduce further episodes of syncope. Syncope is defined as a sudden brief loss of postural tone and consciousness associated with rapid recovery, usually within 1 minute, without prolonged post-recovery symptoms such as post-recovery confusion, or prolonged alteration in consciousness, and it should be caused by a transient global decrease in the cerebral blood flow. Now, the cerebral blood flow is governed by the cerebral perfusion pressure, which is given by the mean arterial pressure minus the intracranial pressure, and the major component of that in regards to syncope is the mean arterial pressure. That is given by the following equation: mean arterial pressure minus the central venous pressure is equal to the cardiac output times the systemic vascular resistance. So you can see that the cardiac output and systemic vascular resistance are the major components governing the mean arterial pressure. And so the drop in cerebral blood flow can be caused directly by a fall in cardiac output, a decrease in systemic vascular resistance, or a combination of both. Understanding this concept is very important because it helps us to classify syncope into various subtypes. The following diagram here is taken from the European Society of Cardiology guidelines on syncope, and it nicely illustrates the three major types of syncope that we see in the cardiac telemetry unit. Starting from the middle of this disc, we see that all syncope is related to a transient decrease in cerebral perfusion, often caused by low blood pressure, and that can either be due to low cardiac output or a decrease in the systemic vascular resistance. Now, causes of low cardiac output include what are called the cardiac syncopes, which in turn include things like arrhythmias, structural heart disease, and other etiologies such as pulmonary emboli and aortic dissections. In addition to direct cardiac causes of low cardiac output, it can also be due to certain subtypes of the reflex syncopes, which are associated with a reflex increase in the vagal tone, which will in turn decrease heart rate and lower the cardiac output. These are the cardioinhibitory forms of reflex syncope. Finally, as another cause of low cardiac output, the patient can be intravascularly volume depleted or have significant pooling of the blood in the venous system, which will lead to a subtype of what are called the orthostatic forms of syncope. On the other hand, low peripheral vascular resistance can be also mediated by increased vagal tone and relative decrease in the sympathetic tone seen in reflex syncope, and that's the vasodepressor subtype of reflex syncope. It can also be seen in orthostatic forms of syncope whenever there's damage to the autonomic nervous system, as seen in Parkinson's disease and neuropathies such as diabetic neuropathy. Finally, you can see orthostasis as a direct result of drug-related side effects, and these can be related to a wide list of drugs that will interfere with the ability of the autonomic nervous system to regulate the blood pressure. And so in summary, we have the reflex syncopes, which are the most common type of syncope mediated by an increase in vagal tone, orthostatic syncope, which are associated with positional changes in the body's ability to regulate the blood pressure, and the rare but very dangerous cardiogenic subtype of syncopes, which are related to structural heart disease, arrhythmias, and other serious conditions. In addition to these standard forms of syncope, we also have many syncope mimics. And these are conditions that will meet some but not all of the criteria for syncope, but are often mistaken for syncope by physicians and other healthcare providers responsible for triaging patients who present with loss of consciousness or fainting episodes. The subclavian steal syndrome is associated with narrowing of the subclavian artery proximal to the takeoff of the vertebral artery. So there's the vertebral artery, and this is the subclavian. When there's narrowing of the subclavian proximal to the takeoff of the vertebral artery, whenever there is a demand for increased blood flow to the arm, blood in the vertebral artery, which is responsible for supplying the posterior circulation and brainstem, which contains the centers for control of consciousness in the brain, flows backwards down the vertebral into the subclavian. And so the transient decrease in vertebral flow will cause loss of consciousness and syncope. And these symptoms will most commonly be occurring during situations wherein the patient needs to use their arm, such as reaching overhead. More generally, any condition that leads to decreased vertebral artery flow and impairs circulation of the brainstem, which will cause syncope, will cause loss of consciousness. And these are termed vertebro-basilar insufficiencies. Depending on the source, these may or may not be classified as true syncopes. In cases where they are classified as true syncopes, they're usually grouped under a fourth category called neurogenic syncope. Seizures, on the other hand, are one of the most common syncope mimics, but they are never to be classified as true forms of syncope, since they're not usually related to impairment in cerebral blood flow, but rather an abnormal electrical activity in the brain. Then there are the psychogenic mimics of syncope, which would include psychogenic pseudosyncope and pseudo-seizures. Cataplexy is associated with a loss of postural tone, but not a loss of consciousness. This is a prominent feature of narcolepsy. Alcohol intoxication acutely can cause loss of consciousness, but should not be confused with syncope. Many metabolic derangements, especially hypoglycemia and hypercapnia, can cause a sudden loss of consciousness, but again should not be confused with syncope. In order to differentiate syncope versus seizure, which is a common problem for emergency departments and internal medicine physicians alike, it's critical to obtain as much history as possible from as many sources as you can. One feature is that in syncope, if there is a prodrome where the patient complains of symptoms just prior to the loss of consciousness, they're usually associated with things like lightheadedness, palpitations, sweating, or feeling of warmth. Whereas in seizure, they may report auras with neurologic symptoms like a generalized feeling of unease, a feeling of déjà vu, or lateralizing symptoms such as unilateral arm or leg twitching. Again, going back to the definition, syncope is usually brief, often less than a minute, and involves full recovery without any confusion, whereas seizures tend to be more prolonged and are associated with what are called the post-ictal states, which include confusion and post-seizure paralysis. Often people asked about the presence of any witnessed jerking movements, which classically would suggest seizure activity, but in reality don't really help differentiate, because people with syncope can also have similar jerking movements during their episode. Bowel incontinence is almost never associated with true syncope, although urinary incontinence can be seen in both. Physicians should always ask about tongue biting, although it can be present during both. Although if tongue biting is present during syncope, it's usually limited to the tip of the tongue, whereas in seizures, it can be associated with the back of the tongue. Next, we'll move on to a discussion of the individual syncope subtypes in detail, starting with reflex syncope. This is a fall in cardiac output and or the systemic vascular resistance mediated by an overactive vagal reflex. There's a few subtypes of this. The first is neurocardiogenic, or the vasovagal subtype. The pathophysiology of this is that it starts with a sudden sympathetic surge that leads to hyperdynamic contractions, which empty out the ventricles. And then shortly after this, there is a strong vagal response, which leads to bradycardia, vasodilation, and an acute fall in the mean arterial pressure, which contributes to the syncope. This is probably one of the most common types of syncope, and fortunately one of the most benign as well. Carotid sinus hypersensitivity is when the vagal reflex is unusually strongly stimulated by activation of the baroreceptors in the carotid sinus. So this is usually triggered when a patient is shaving or wearing a tight shirt. The baroreceptors will be stimulated and generate an unusually strong vagal reflex, causing syncope. Some situational triggers of syncope or reflex syncope are associated with any condition that would lead to an increase in the vagal tone. That might include micturition, defecation, blood draws, or severe pain. In this diagram, it's illustrated the reflex arc of the vagal response. So it starts with the carotid sinuses in the just around the area of the carotid bifurcation. Whenever these are stimulated, they carry signals via the cranial nerve 9 or glossopharyngeal nerve to the brainstem, and parasympathetic output is mediated by the vagus nerve, which would go to the sinus node in the heart, as well as affect sympathetic fibers going to the smooth muscle in the arterioles. And this in turn will lead to a fall in cardiac output and a decrease in the systemic vascular resistance. Orthostatic syncope is associated with the inability of the sympathetic nervous system to compensate for a sudden drop in venous return to the right side of the heart, caused by a sudden change in position from being supine or seated to standing. It's commonly associated with the physical exam finding of orthostatic hypotension, which is a drop in the patient's blood pressure of 20 millimeters of mercury systolic or greater than 10 millimeters of mercury diastolic when they go from a supine to a standing position. Causes of orthostatic syncope include hypovolemia or blood loss, leading to intravascular volume depletion, autonomic dysfunction, as occurs in diabetic neuropathy and Parkinson's disease, where it can be part of the Parkinsonian syndrome, multiple system atrophy, formerly known as Scheidegger syndrome. Multiple sclerosis, as it can also involve the conduction pathways linking the components of the autonomic nervous system, can also lead to autonomic dysfunction, as can alcoholism, which also causes a neuropathy. Drug-induced forms of orthostatic syncope, again, are related to drugs that impair the ability of the autonomic nervous system to vasoconstrict when a patient changes position. These would include calcium channel blockers, alpha-1 blockers, such as prazosin and terazosin, which are often given for BPH, beta blockers, nitrates, tricyclic antidepressants, antipsychotics, and of course diuretics, which would cause intravascular volume depletion. A certain subtype of orthostatic syncope is called the postural orthostatic tachycardia syndrome, or POTS syndrome. This is characterized by an increase in the patient's heart rate by 30 beats per minute or more on standing, not associated with orthostatic hypotension, and characterized by symptoms of dizziness, lightheadedness, and also syncope when a patient changes position. Finally, the most dangerous subtype of syncope, cardiogenic syncope. This can be caused by any tachyarrhythmia, particularly ventricular tachyarrhythmias, but in some cases also supraventricular tachyarrhythmia, such as atrial fibrillation. In these cases, it's usually not the tachyarrhythmia itself that leads to syncope, but the period of bradycardia or sinus pause, which occurs when the tachyarrhythmia breaks as a result of overdrive suppression of the SA node. Bradyarrhythmias, which include sick sinus syndrome, high-grade AV blocks, can also cause a decrease in cardiac output and syncope. Ischemic heart diseases and MI can also cause a decrease in cardiac output. Structural heart disease, particularly aortic stenosis, hypertrophic cardiomyopathy, or HOCM, the cardiac tumor called the atrial myxoma, cardiac tamponade, and vascular abnormalities such as the anomalous left main coronary artery from the pulmonary artery. And this last condition, although very rare, leads to perfusion of the coronary arteries using venous blood directly from the pulmonary artery before it gets oxygenated, and this can lead to early onset of MIs. Pulmonary emboli and aortic dissections are also very rare causes, but can be very fatal. When evaluating a patient with syncope, a proper history is essential in order to identify whether a patient truly has syncope and also to identify possible causes. Some of the key questions to ask a patient are whether they had any prodromal symptoms prior to the event, whether they can recall any precipitating events, or if they've noticed that the symptoms came on after a change in position. If the symptoms were brought on immediately after exercise, this could point to a vasovagal episode, as well as cardiogenic causes such as hypertrophic obstructive cardiomyopathy and aortic stenosis. Also ask whether the patient experienced any palpitations. This might point to an arrhythmogenic cause of syncope. Whether there were any post-event symptoms, remembering that true syncope itself is almost never associated with prolonged post-event symptoms. And then ask if the patient had any prior episodes similar to the episode that they currently experienced, or whether they have any known family history of sudden cardiac death. In addition, always ask if the patient can recall, or any witnesses can recall, how long the episode lasted for. Again, remembering that true syncope shouldn't last for more than 5 minutes. To speak with as many witnesses as possible. Ask about bowel or bladder incontinence, tongue biting, presence or absence of myoclonic jerks, and Often most importantly, try and obtain an accurate medication list, either by asking the patient, checking records, or calling the patient's pharmacy, especially to look for drugs that can induce orthostatic syncope. Physical exam tests to specifically focus on a patient with suspected syncope would include obtaining orthostatic vital signs. This should be done immediately after a patient presents to the emergency room and prior to the administration of any IV fluids, as this may alter the results of the testing. In order to do this, check the patient's blood pressure and heart rate after 5 minutes after the patient's been lying supine, 3 minutes after the patient has been in a seated position, and then another time 3 minutes after the patient stands. Again, if the blood pressure drops by greater than 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic, this is considered a positive test. The orthostatic test is also considered abnormal if the patient's heart rate either fails to rise on standing or rises excessively, as in the postural orthostatic tachycardia syndrome. Another useful test, which can be performed in patients who are not suspected to have any carotid atherosclerosis, is the carotid massage. Following a carotid massage, if the patient reports recurrence of their symptoms, experiences a fall in their blood pressure, or experiences a 3-second or more sinus pause on telemetry, this is considered a marker of carotid hypersensitivity. You should consider this test, especially in patients who report syncope associated with certain triggers such as shaving or wearing tight shirts. A good cardiac examination, specifically focusing on the presence of arrhythmias or murmurs, can help identify structural causes of heart disease. In this diagram, we see an example of how to perform the carotid massage, feeling for the first firm prominence in the neck, which would be the thyroid cartilage, and just lateral to that is approximately the location of the carotid bifurcation where the carotid sinuses are located. Holding that area firmly and briefly for a few seconds should be enough to elicit a carotid hypersensitivity response. Obtaining a 12-lead ECG is a critical part of the evaluation of any patient who presents with syncope. Some of the patterns on the ECG to watch for that might indicate concerning cardiac causes of syncope would include any signs of acute ischemia, which would be new Q waves, ST elevations, ST depressions, T wave inversions. Any advanced AV block, such as a Mobitz 2 AV block or third-degree AV block, as well as first-degree AV block with a markedly prolonged PR interval greater than 400 milliseconds. Atrial fibrillation with a slow ventricular response is particularly concerning, as it can indicate problems with AV nodal conduction. Persistent bradycardia or sinus pauses greater than 3 seconds can indicate the need for advanced intervention such as pacing to prevent further episodes of syncope. A new right or left bundle branch block, alternating bundle branch block, or a bifascicular block, which would be the combination of a right bundle branch block with a left anterior fascicular block or a left posterior fascicular block, would be suggestive of progressive conduction system disease, which can eventually progress to a complete heart block, and this should be addressed as well. Any episodes of ventricular tachycardia, either sustained or non-sustained, or frequent polymorphic PVCs, which would be particularly concerning, and any features suggestive of pulmonary embolism or pericardial disease, such as the S1Q3T3 pattern, very specific for PE, or diffuse ST elevations and PR depressions seen in pericardial disease. Some of the rare or more subtle findings, but which should not be missed especially in young patients who present with syncope, would include long QT, a Brugada pattern, evidence of pre-excitation or WPW syndrome, the ARVC pattern, pattern suggestive of hypertrophic obstructive cardiomyopathy, and again, features suggestive of either PE or pericardial disease. And we'll go through each of these in detail. The long or short QT syndrome is associated with severe ventricular tachyarrhythmias and should not be missed. In this ECG, it's roughly normal, except for the fact that the T wave is occurring almost right before the following QRS complex. If you measure the QT interval, which would be the start of the Q to the end of the T wave, you can see that it's clearly more than half of the corresponding R to R interval, which should automatically raise concern for prolonged QT, especially if the patient's heart rate is normal cardiac, which it is in this case. Ideally, the QT interval should be less than 440 in men or less than 450 in women. Longer than this is considered prolonged, although generally severe symptoms don't manifest until the QT becomes greater than 500 milliseconds. Certainly a QTC greater than 480 should raise concern, and physicians should consider avoiding administering any QT prolonging agents. In this particular patient, the QT prolongation was actually due to severe hypocalcemia, which is one of the most definitive findings in hypocalcemia, but it can also be due to drugs and inherited conditions such as the Romano-Ward syndrome and the Jervell-Lange-Nielsen syndrome. Short QT syndrome, where the QTC is less than 360 milliseconds, is much more rare, but can equally be associated with severe ventricular tachyarrhythmias. Again, always think carefully about medications that would cause QT prolongation. And you can consider adding beta blockers both to suppress ventricular tachyarrhythmias and to slow the heart rate, as slower heart rates are associated with less risk of precipitating polymorphic ventricular tachycardia or torsades in patients with markedly prolonged QTs. In this sample from an ECG showing leads V1, V2, and V3, we see particularly in leads V1 and V2 an R, S, R prime pattern associated with a downsloping ST elevation and T wave inversion. Again, R, S, R prime with a downsloping ST elevation and a T wave inversion. Whenever you see this pattern on an ECG, you should suspect the Brugada pattern. And when this pattern is associated with symptoms such as syncope or visualization of ventricular tachycardia on a telemetry monitor, this is termed the Brugada syndrome. Caused by inherited mutations in sodium channels. It does have three types, although the type 1, which is depicted here, is the most clinically significant and associated with severe arrhythmias and sudden cardiac death. Generally, when you see a type 1 pattern, particularly when the patient presents with syncope, they need to be referred for ICD placement in order to prevent further episodes of VT that can cause syncope and even sudden cardiac death. This ECG here is associated with a very short PR interval. You can see the P wave is sitting right on the tail end, right just before the QRS. The QRS itself is unusually wide, and it has a slurred upstroke, as you can see here, 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 here. here and here. So the combination of the short PR interval and the slurred upstroke, also called the delta wave, in many of these leads is characteristic of Wolff-Parkinson-White syndrome, or pre-excitation syndrome, caused by an accessory pathway linking the atria and ventricles and bypassing the AV node. As these patients are prone to severe arrhythmias such as atrioventricular reciprocating tachycardia, or AVRT, they can certainly be at much, much higher risk of developing episodes of syncope. Again, it's caused by the presence of accessory pathways. In this case, based on the morphology of the delta wave, positive in all the precordial leads, with a net positive QRS complex in V1, we can say that this is a type A WPW, which indicates that the accessory pathway is in the left side of the heart. Another rare cause of cardiogenic syncope is called arrhythmogenic right ventricular cardiomyopathy. Here is an ECG from a patient with this condition. And the most prominent findings here are the inverted deep T-wave inversions in most of the precordial leads, V1 through V5, as well as the inferior leads. And the arrows here, the red arrows, point to a small positive deflection just at the end of the QRS complex in V1, V2, and V3. These are called epsilon waves, and they're relatively pathognomonic for this condition, although it's a poorly sensitive finding. This condition is caused by an inherited defect in the desmosome proteins, which are the proteins on the myocyte membranes that help to conduct electrical signals from cell to cell. And as a result of these mutations, the right ventricle in particular is replaced, its muscle is replaced with fibrofatty tissue, which is poorly contractile and highly prone to developing severe fatal arrhythmias. These patients also typically receive ICDs to prevent further episodes of VT. Hypertrophic cardiomyopathy is a common condition associated with sudden cardiac death, particularly in young, healthy athletes. The ECG findings that might point to a diagnosis of hypertrophic cardiomyopathy would include severe LVH, particularly in a young, healthy patient with no other reason to have LVH, no significant uncontrolled hypertension, as well as these thin, deep dagger-like Q waves, which are caused by asymmetric septal hypertrophy. This condition is caused by a genetic mutation in the troponin proteins, as well as some other structural muscle proteins. An echocardiogram would be very helpful in diagnosing this condition. You're going to look for asymmetric septal hypertrophy and what's called systolic anterior motion of the anterior mitral valve leaflet, or SAM. On physical exam, these patients will have a crescendo-decrescendo murmur, systolic murmur, very similar to aortic stenosis, but unlike aortic stenosis, it would be worsened by a prolonged Valsalva maneuver rather than improved. Here's one example of an ECG from a young patient with hypertrophic cardiomyopathy. You see the particularly large QR voltages in the precordial leads, tall R wave in V4, V5, with deep S waves in V2 and V3. These are also associated with secondary repolarization changes with deep symmetric T-wave inversions in the anterior precordial leads. This is another example of a patient with hypertrophic cardiomyopathy. Again, there's deep S waves in V2, but the most prominent feature are these prominent Q waves in V4, V5, and V6, the lateral leads. And again, these are due to the prominent septal hypertrophy. They're distinguishable from Q waves associated with myocardial infarction in that they're very narrow, less than 40 milliseconds wide. Finally, one more condition associated with syncope and sudden cardiac death is called Catecholaminergic Polymorphic VT. This is another inherited disorder where individuals will develop episodes of VT during times of extreme stress or during exercise. It can sometimes be diagnosed by having a patient exercise while on a cardiac monitor and looking for episodes of VT. Patients with this condition are advised to avoid exercise as much as possible and take beta blockers with the possibility of adding on antiarrhythmic therapy as second-line agents. So what do we do when we get a patient who comes into the emergency department with an episode of loss of consciousness and you suspect syncope? Many of these patients do wind up getting admitted to the cardiac telemetry unit for further testing, but do they really need to be? So there are some patients who can actually be discharged directly from the ED. These are the young patients with a very classic story for reflex or vasovagal syncope and no high-risk features on their ECG or history. On the other hand, we should be admitting patients with any concerning ECG findings, electrolyte abnormalities, any history of structural or ischemic heart disease, or any reported family history of sudden cardiac death. And patients who report syncope that was associated with exertion, associated with being at complete rest, or that occurred without any warning at all, which is often a sign of cardiogenic syncope. There are clinical prediction tools available, such as the San Francisco Syncope Rule, which is perhaps the most famous of them. It has 98% sensitivity for identifying life-threatening syncope causes. The San Francisco Syncope Rule uses the acronym CHESS, with C standing for any history of congestive heart failure, CHF, H standing for hematocrit less than 30, E standing for any abnormal ECG findings that we discussed before, S standing for shortness of breath or dyspnea, and the second S standing for systolic blood pressure less than 90. Patients with any of those findings or history features should be admitted. Similarly, there's also a Canadian syncope risk score, which is, in my experience, less widely used. Here's a flow chart summarizing the next diagnostic steps for a patient who presents with syncope. It starts with an initial evaluation, including a thorough history and physical. And the first question to ask is whether the patient's symptoms are consistent with the definition of syncope, or whether you should be thinking more of other causes for the patient's symptoms or loss of consciousness. If it doesn't sound like syncope, then consider alternative causes and perform laboratory testing and imaging to work up those possible alternative causes. And then if it does sound like syncope, the patient should definitely be getting an ECG and an orthostatic vitals evaluation. From there, patients who have a story consistent with either reflex or orthostatic syncope, they report that their syncope worsened consistently every time they stood up or was associated with typical prodromal symptoms suggestive of vasovagal episodes, and they don't have any concerning ECG findings. They don't require any further invasive or cardiac testing. And after they have their underlying problems dealt with, they can often be discharged early. On the other hand, patients who have sudden syncope, syncope associated with exertion or rest, any suspicious ECG findings, or a history that was suggestive of cardiac syncope should be admitted to the cardiac telemetry unit, undergo a transthoracic echocardiogram, and be placed on at least 24 hours of continuous telemonitoring. After this evaluation, if a patient is found to have any condition that would place them at higher risk for developing episodes of VT, such as any of the inherited structural or channelopathy disorders, or if episodes of VT were directly seen on telemetry, they should be referred for an ICD placement. They should also be referred if they meet the criteria for ICD based on low ejection fraction heart failure with an EF less than 35. Patients with other causes of arrhythmia, such as the Wolff-Parkinson-White syndrome or supraventricular tachyarrhythmias, can be referred for an EP study to ablate the source of the supraventricular tachycardia or accessory pathway. In patients who are found to have structural heart diseases that might be contributing to their syncope, such as aortic stenosis and hypertrophic obstructive cardiomyopathy, can be referred for invasive intervention. Patients who were admitted to the cardiac telemetry unit and had essentially a negative workup for cardiac findings can then be evaluated for causes of vasovagal or orthostatic syncope, and if those are unrevealing, they can have ambulatory ECG monitoring to look for other causes of arrhythmias. And if any of those are found, they can also be referred for EP study or ICD placement. So the proven tests that would be most likely to catch a treatable cause of syncope would be ECG, an evaluation for orthostatic hypotension or tachycardia, telemonitoring, which you would usually start with inpatient telemonitoring for 24 to 48 hours, but can be extended with ambulatory ECG monitoring if necessary. Echocardiogram in high-risk patients who are suspected to have aortic stenosis or hypertrophic cardiomyopathy. And sometimes electrophysiology studies, particularly in the patients with evidence of arrhythmia. Here's an example of an unusual echo finding in a patient who presented with syncope. Here we see an apical four-chamber view of the heart. This would be the right ventricle, right atrium, and left ventricle. We see in the left atrium an unusual echo-dense structure sitting right inside the chamber. This is an atrial myxoma, and if this tumor plops down and blocks off mitral inflow to the left ventricle, this can decrease cardiac output acutely and lead to syncope. Once the obstruction is relieved by the tumor moving away, blood flow is restored and the patient recovers quickly. Unfortunately, many patients who present with syncope are referred for often expensive, invasive testing, particularly those without any concerning history or physical or ECG findings that would warrant such testing. And this can cost the healthcare system a lot of money and cause the patient an unnecessary burden. Some of the unnecessary tests that are ordered for patients who present with syncope include carotid ultrasound to evaluate for carotid artery stenosis. One important reason why this is unnecessary and often not very useful for patients with syncope is that the carotid arteries supply the anterior circulation to the brain, and carotid occlusion, unless severe and bilateral, is unlikely to cause a syncope. On the other hand, vertebro-basilar insufficiency, as discussed previously, is likely to cause syncope, but this would not be seen on a carotid ultrasound. Ordering an EEG or advanced brain imaging, such as an MRI, is clearly unnecessary, as we can often distinguish between structural brain diseases, such as seizures, which would warrant such testing, from syncope on the basis of history alone. A CT head won't help you to diagnose syncope, but might be useful in patients who did present with loss of consciousness and may have had head trauma. Serial troponin levels to look for signs of cardiac ischemia are not often useful. They should be ordered in patients who you have alternative reasons to suspect ischemia, but not for patients presenting purely with syncope, as syncope is not really a common initial presenting symptom of an MI. Finally, there is the tilt table testing, which is sometimes done, but not recommended in most cases of syncope. Here's a diagram of how that works. So a patient is strapped to a table. The patient is initially lying flat with the head of the bed resting against this metal support, and then suddenly the table is tilted so that the patient is suddenly standing upright. Meanwhile, the patient is hooked up to a cardiac monitor and a blood pressure cuff to record their orthostatic vital signs. Rare situations where this may be done are in patients with recurrent syncope or those in high-risk professions such as surgeons who do need to be remaining standing for extended periods during the regular course of their jobs, and who would greatly benefit from recognizing and treating their orthostatic syncope. Ambulatory ECG monitoring is an option for patients who present with recurrent syncope with suspicious cardiac features, but no clear cause identified in initial workup. Some of the options that we use for these patients would include the basic Holter monitor, which is a basic ECG monitor worn around the neck for a short period, and it's useful for recording episodes that are fairly frequent and occur daily. Then there's the event recorder, which is a handheld portable device that the patient holds up to their chest to record their ECG whenever they start to feel prodromal symptoms. Not very useful when a patient has sudden syncope without warning. There are also certain long-term ECG monitors worn transcutaneously as a patch available, and this can record the patient's rhythm continuously for up to 30 days. And finally, the most long-term solution, useful for patients with very spread-out episodes that occur very infrequently, is the implantable loop recorder. This can be left in for months. It does require a somewhat invasive procedure where the device is inserted subcutaneously, and it can also be patient-triggered. The patient can have a app on their smartphone that can record their rhythm, and they can even press a button to indicate when they're having symptoms, just like the event recorder. Here's a picture of a patient wearing a Holter monitor, worn around the neck with ECG leads coming off it that continuously record the patient's rhythm, very temporary solution. This is an event recorder. The patient holds this up to their chest anytime they feel symptoms, and it'll record their rhythm. This is a long-term ECG monitor worn as a patch. And finally, an implantable loop recorder. You have a little device the size of a USB and implanted subcutaneously underneath the patient's skin near their heart, and this can transmit data and be interrogated to identify any arrhythmias over the long-term period. Patients who've been ruled out for any serious cardiac causes of syncope that can be either ablated or corrected with an ICD have a few options. They should be counseled to avoid from being dehydrated, to drink plenty of water, and try preload increasing maneuvers or wear compression stockings during the day to improve their venous return. You should do a careful medication reconciliation and reduce their doses of antihypertensives, stop them if they're not necessary, and also stop other medications that you think may be contributing but aren't really providing a lot of benefit to your patient. Particularly consider stopping those medications such as alpha blockers, beta blockers, calcium channel blockers that can be contributing to orthostasis and dysautonomia. There are also medications that are specifically designed to help with refractory cases of orthostatic hypotension. This would include midodrine, which is a oral pressor used as a vasoconstrictor, and fludrocortisone, which will increase sodium retention as it acts as a aldosterone mimic and prevent the patient from becoming intravascularly depleted. In the past, it was suggested that patients who have recurrent vasovagal episodes be started on a beta blocker, but this is much less common and no longer advised. Again, patients without any clear prodromal symptoms that are suspicious for cardiogenic causes of syncope should get referred for ILR monitoring, a loop recorder, and get pacemakers if they're noted to have episodes of bradycardia or sinus pause. Here's an example of a set of instructions offered to a patients, specifically in this case with postural orthostatic tachycardia syndrome, but which can also be helpful for patients with vasovagal and other orthostatic forms of syncope to increase their preload. This includes squatting, which would greatly increase the cardiac preload, and leg exercises like the toe raise and leg crossing. In summary, syncope is a condition characterized by a brief transient loss of consciousness with rapid recovery, usually within minutes. It's divided into reflex, orthostatic, and cardiac subtypes, where the reflex is caused by an increased vagal tone, orthostatic caused by either decreased circulating plasma volume or an impairment in the autonomic nervous system, and cardiac subtypes, which relate to arrhythmias, structural heart diseases, and other causes including pulmonary embolism and aortic dissection. There are many syncope mimics, which you should be aware of, that don't completely fit the criteria of seizures. Particularly to watch out for are seizures, which can often be distinguished based on a careful history. High-risk features for syncope would include abnormal ECG findings, syncope that occurs without warning, syncope that occurs at rest, syncope associated with suspicious murmurs, extra heart sounds, or any family history of sudden cardiac death. These patients almost always need to be admitted for further evaluation. A basic evaluation for any patient presenting with syncope should include an ECG to look for those suspicious findings, obtaining orthostatic vital signs as soon as possible, and a brief period of telemonitoring. Further investigations for syncope, including EP studies, echocardiogram, and possibly long-term ambulatory ECG monitoring, should be guided by the results of these initial evaluations and the patient's history. You should avoid ordering unnecessary tests such as carotid ultrasound of the neck and MRI ECGs for these patients, as they're considered to be very low yield tests. And that's all for my lecture on syncope. Thank you very much and have a great day.